Good morning, everybody. And it's a real pleasure to be here. I last had an opportunity to speak at IPOKRaTES I think it was 2004 in Innsbruck. You guys have grown. So congratulations. I don't know whether you're the father, the grandfather, or the great-grandfather of this organization, George. But you should... Many functions. You should take great pride in its success. Thank you, Judy. And especially thank you to Carl and Gunnar for wonderful hospitality in this lovely town. I'm going to learn a lot here. I think especially I'm going to learn a lot about beer because this is really quite a center for that. Pardon? Put this in my... do you have the point? Oh, here it is. Good. So if the acoustics is a problem, let me know. And this is, can you make it a little, so you can see the slides a little better? Is it possible to dim the lights a little bit? It's a little, it might be nicer. Is it possible, do you think, to take it? Otherwise, we'll try. So this has been my home. I'm originally from Australia. In case you wonder about my accent, you may recognize it. This has been my home for really my entire academic career at Rainbow Babies and Children's Hospital in Cleveland. Some of you have been there. It's been a wonderful place for me, for neonatology, and in fact, I'm honored to represent the group here at your meeting this morning. So I'm going to talk about 4 different things, spend a little bit more time on some than others. I'm going to start by talking a little bit about the pathobiology of apnea of prematurity, and then as you see, we'll go through and finish up, of course, with management and outcome of these events that infants have. And maybe it's appropriate just to remind ourselves that, of course, the fetal to neonatal transition, which is always a nice way to begin a meeting, is associated with going from very intermittent respiratory movements, which have nothing really to do with gas exchange, to now the need postnatally to breathe continuously. So there are obviously inhibitory mechanisms that are going on in utero that inhibit respiratory neural output and that make it really breathing to be intermittent. It makes no sense for a fetus to breathe, have respiratory movements 60 times a minute. And there's a variety of mechanisms that have been studied to try and understand what inhibits respiratory neural output in utero. As you can see here, I'm not going to go through. I'm just going to mention 2. Certainly, we know that the PO2 in utero is low. You'll hear more about that during this meeting. Adenosine is released by hypoxia, and adenosine is a potent respiratory inhibitor. We're going to talk about that a little bit more when we talk about caffeine, which is, of course, a non-selective adenosine receptor inhibitor. There's an interesting story over here in the fact that prostaglandins are released by the placental unit, and prostaglandins are also inhibitory of respiratory neural output, and as you'll hear in a few moments, probably play a role in the apnea that septic babies have. And you can see a variety of other mechanisms here. And by the way, I believe you have a handout, so if I don't cover everything in every slide, I think you should have access to that. If we just say a couple of words about respiratory control and the physiology, I would just like to remind you that the major chemical driver of breathing is CO2. And CO2, or carbon dioxide, which stimulates breathing, is sensed primarily centrally at the brainstem, on the ventral surface of the medulla, which, as you see here, by this little yellow arrow. We'll talk a little bit very briefly later on about people that have actually used small concentrations of CO2 to stimulate breathing. The story with hypoxia is a particularly interesting one. And unlike CO2, which is sensed primarily centrally, the hypoxic drive to breathe, which is, of course, very important in all of us when we increase our breathing in response to hypoxia, is sensed probably exclusively peripherally at this location, at the carotid body and the aortic body, situated pretty much as you see here at the bifurcation of the great vessels. Now, this story is a little complicated, and this is probably the most complicated slide I'm going to show you, but I'm just going to spend about 1 or 2 minutes on this. If hypoxia stimulates breathing, then obviously hyperoxia will inhibit breathing, which is one of many reasons why if a baby has apnea, we don't want to suddenly give the baby 100% oxygen. There are many other reasons why we wouldn't want to do that. Obviously, that will delay the onset of breathing. And I'm sure you're going to hear quite a bit at this meeting about the fact that we have moved away from resuscitating babies unnecessarily many times with 100% oxygen. And in fact, one of the first things that was observed by the pioneers of this field, both Europeans, Ola Sogstad in Norway and Maximo Vento in Spain, was that if you resuscitate a baby with 100% oxygen, it will take longer for that baby to start breathing, which is a nuisance or a problem, depending on how you look at it. And obviously, what happens if you have postnatal hyperoxia, you will shut down the peripheral chemoreceptors and you will have delayed onset of breathing. The story over on this side is interesting. I'm just going to spend 1 minute on this. There's a lot of interest in a subject known as chronic intermittent hypoxia. It's probably driven in large part by the fact that many adults have sleep apnea. They have sleep-disordered breathing. This is associated with recurrent hypoxia. It may, in fact, be associated with hypertension, diabetes, a lot of other potential problems. And in the neonate, we're only beginning to explore this phenomenon. But obviously, if you have decreased respiratory drive, you have a recurrent apnea, you have a recurrent intermittent hypoxic episodes, this has actually been shown in a variety of animal models to increase peripheral chemosensitivity, and that's not a good thing either. It's as if the peripheral chemosensors, it's sort of like good food or good wine. If you have none, it's bad. If you have too much, it's probably bad too, because you then have a very unstable situation where you might have something like this. In neonates, it's been shown by groups in Winnipeg, Canada, and others that in fact the CO2 at which the babies operate is very close to their apneic threshold, which is the CO2 at which your breathing shuts down. You now superimpose that on an unstable system where you have upregulated peripheral chemoreceptors, and you can see you're bouncing around all over the place. And in fact, periodic breathing, which I'll say a word about later, but periodic breathing, which all our premature babies do, and which is probably a benign phenomenon, is related to upregulation of these peripheral chemoreceptors superimposed upon a CO2 that is close to the apneic threshold. And that's sort of probably the major explanation for one of the most common breathing patterns we see in our infants. So anyway, the primary problem is decreased respiratory drive. As a result of decreased respiratory drive, you have apnea, you have decreased ventilation. That in turn will lead to hypoxemia or desaturation, obviously. And then via reflex events probably related to the carotid body, not actually that well understood, hypoxia probably results in bradycardia, and it's dependent on the carotid body associated with hypoxia. There may also be, and of course, the sequence of events typically is apnea, desaturation, bradycardia. There may also be some instances where bradycardia is associated with an increase in vagal tone associated with apnea. One of the biggest problems, of course, we measure three things, right? We measure breathing, we measure oxygenation with pulse oximetry, and we measure heart rate. And one of the biggest, most troublesome problem we have is these recurrent episodes of desaturation that we identify in our babies. This is a nice model developed by a group in Australia fairly recently, showing some of the factors that influence arterial oxygen desaturation during apnea. For example, any of us, we can probably stop breathing for 20 seconds. A term baby can probably have an apnea for 20 seconds and will be very unlikely to desaturate and get hypoxemic. And yet some of our preemies, 5-second pauses, 8-second pauses, and their oxygen comes down immediately. And that's probably related in large part to most of our preemies have problems with pulmonary oxygen stores. They have problems with their lung function. Even if they're in room air, often their compliance is a little bit low, their resistance is a little bit high, their lung volume is low. So it doesn't take much in the way of impaired lung function for cessation of breathing to be associated with desaturation. There's also other factors that will affect the rapidity of desaturation. for example, total oxygen blood capacity or hematocrit. I'll say a word about that in a moment. Slope of the hemoglobin dissociation curve, and probably also peripheral oxygen consumption, which may be affected, for example, by such things as giving caffeine to our infants. Now we have another problem, and that is our impedance monitors, which we have in the nursery, are not very effective in telling us what's going on. Thankfully, we have heart rate and oxygen saturation as well to fall back on. So here you see an exaggerated example of a problem. Here you see a baby. Here you have impedance monitors that are just telling us that the chest is moving, okay? So here you have an impedance monitor which thinks here in the middle this baby's having a respiratory pause of about 10 seconds duration. Here you see this baby is getting bradycardic. If we were to measure tidal volume, which of course we don't have, we would need a mask, we would need to measure nasal airflow, mouth flow. It's not practical. If we were to measure ventilation in this baby, you would see that this baby is not breathing for about 30 seconds. So what's happening is there is a short, what we refer to as central apnea. Respiratory neural output is stopping, okay? Now you have a closed upper airway, you've got loss of respiratory neural output, the upper airway closes, now the baby starts having inspiratory efforts because CO2 is going up, O2 is going down, and you can see these inspiratory efforts are ineffective because the upper airway is closed. Fortunately, we have heart rate and we have oxygen saturation. If you now come onto this baby, if you intersect at this point, an alarm is going off, the doctor or the nurse comes to the baby, you will see a baby whose chest wall is moving, whose heart rate is 60, and you see how it's very easy that someone's going to say, aha, this baby's got a bradycardia. Well, that's true, the baby has a bradycardia, but that is not the primary problem. The primary problem is that this baby is not breathing and now has an obstructed inspiratory effort. And this is another example of that, probably the way it happens more often. Here you have this is a technique known as respiratory inductance plethysmography, a little more detailed where you measure rib cage movement here, abdominal movement here, and the sum is a semi-quantitative sum of the two. You can see this baby is not breathing. You can see towards the end of the respiratory pause here, the second half, you can see some movement of the abdomen, movement of the chest wall. It's small movement, but it's enough to confuse the impedance monitor, okay? The impedance monitor thinks these are breaths, okay? Again, the baby is desaturating down here, so we have these other ways of telling us what's going on. And just to summarize, there's a variety of respiratory muscles. The diaphragm and the intercostal muscles are not the only muscles of breathing. You have these upper airway muscles, probably the most important of which is the genioglossus, or the tongue, which has to contract both phasically and tonically to ensure patency of this upper airway. And when there's loss of respiratory neural output, loss of tone in these muscles, these obstructed inspiratory efforts can seriously prolong most of the longer episodes of apnea that we see in our patients. Finally, before I move on to other aspects of apnea, it's sort of interesting to understand the problem, and summarized in this slide, that there's two things that happen when a baby has apnea. The first is that the baby doesn't generate breathing, and the second is that the apnea doesn't end. So here you've got, I'm not going to go through this, I've covered most of this already, but there's a series of events that are going on here, right? On the one hand, breathing stops. On the other hand, breathing fails to resume. And you could argue the net effect is the same, but the fact remains that these are aggravated by impaired respiratory function, as I told you, and aggravated by upper airway closure. Now, let me spend 5 minutes talking about something which is somewhat newer, I think, and quite interesting, and that is our monitoring techniques have become more sophisticated, particularly our ability to measure heart rate, beat to beat, and our ability to measure oxygen saturation over long periods of time. People have become interested in trying to use the patterning of these cardiorespiratory events, as I call them, to understand a little bit about pathobiology. There's one group at the University of Virginia who are just publishing some of this information now, where they are using cardiorespiratory patterns to try and predict both morbidity and mortality. And one of the things that are out there is they've tried to look at computerizing some of these heart rate and oxygen saturation, particularly heart rate patterns, and they've actually been able to show and predict which of these babies, for example, are more likely to get septic, for example, the next day. And I'm sure you're going to hear more about CBCs and other ways of diagnosing sepsis. But there may be some clues in some of the heart rate patterns based on some of these data that are now published to predict who might have problems. We've focused with our group a little bit on retinopathy of prematurity and oxygen patterns. And this is just a group, if you want to refer to this article, this is some data from the group at the University of Virginia, suggesting that heart rate characteristic monitoring can actually reduce the mortality of these very low birth weight infants, and it's sophisticated techniques that have been employed. And I think Judy Ashner, who's in the audience, has been partaking in this group effort. It's interesting, and my only point is, I mean, is this going to replace the CBCs and the blood cultures and things you guys are doing? Of course not. But on the other hand, I think it's an interesting line of investigation. We monitor all this stuff, right? We have all these monitor tracings, and we're not very good at really using this information to try and predict morbidity and mortality. We've taken a different approach, which is not so much to focus on heart rate, but rather to focus on oxygen saturation. And we've been able to quantify over time. This is some data that were published in the Journal of Pediatrics by my colleague, Julie Di Fiore, a couple of years ago. Here you see in a large number of premature infants, 24 to 28 weeks, over the first 2 months of life. Here you see postnatal age from week 0 to week 8. The number of hypoxic episodes, you can see they're tremendous actually. This is hypoxic episodes of less than 80% of at least 10 seconds duration. Interestingly, these hypoxic episodes are not too much of a problem in the first week or two of life, which is sort of traditionally what we've thought about apnea. They become a problem a little bit later on, and then they gradually decline. I'm going to say a few words more about that later on. And we've been able to look at this in relation to retinopathy of prematurity. And I'm not sure whether we're going to say too much more about retinopathy of prematurity or not at this meeting. It remains a continuing problem. But let me just remind you that there are two phases of the relationship between oxygenation and retinopathy. Initially, you've got this absolute or relative hyperoxia, and of course that can be relative, right? Because when you go from in utero to postnatally, you're hyperoxic, even if you're normoxic, and that shuts down vascular proliferation, probably by inhibiting VEGF and other growth factors. But you then have this second proliferative phase, which is clearly aggravated by hypoxia, particularly intermittent hypoxia. So you've got this shutdown, this pathobiologic shutdown of vascular growth. Now you've got these hypoxic episodes which upregulate VEGF and other growth factors and now cause this proliferative problem. So we had the hypothesis that maybe there is a relationship between the intermittent hypoxic episodes that these babies have and the genesis of retinopathy of prematurity. And as you can see here, this is data that is Journal of Pediatrics, I think this is published, yes, and this looks at the time course of the hypoxic episodes. Postnatal age is on the horizontal axis. The number of hypoxic episodes is on the vertical axis in the babies who develop retinopathy of prematurity, as represented by the orange squares. This is babies who needed laser therapy because we were in the process at that time of defining, and the ophthalmologists weren't exactly agreeing what classification to use. And the babies who did not require therapy for their retinopathy, which represents the green triangles, and you can see hypoxic episodes were more of a problem, as you might expect, in the babies who developed ROP. We're actually extending this right now, and we have some publications coming out and actually a grant which we have submitted, which is under review, so I'm not sure we're going to get the money to do this, but we're sure trying, looking at when you have, and I just want to bring one concept to you, when you have a hypoxic episode as results from apnea, you have a relative hyperoxia associated with recovery from that event, even if it's to normoxic levels. Okay, so there is good evidence from animal models that just here you see an oxygen saturation in the red line of about 80%. You can see this baby's desaturating down to 60, maybe down to 50, recovering even only to 90% to normoxic level. That is a relative oxidant stress, a relative hyperoxia, just associated with this normal recovery. This slide's a little complicated. This is a paper that's in press currently in pediatric research, again from our group. And I just wanted to show you how we need to explore just not the hypoxic events when we look at something like retinopathy of prematurity, but also the recovery between the hypoxic events. And this looks at the time interval between intermittent hypoxic events. And if they're very short, there was no difference between the infants who had developed retinopathy and those who didn't. So, for example, the short recovery periods that you might, for example, see with periodic breathing, probably not a problem here. On the other hand, if there's a longer spacing between the episodes of intermittent hypoxia, probably enough time to give you an oxidant stress and for reactive oxygen species to be developed, formed, then you start having a serious problem here. So when there's a longer time interval of more than a minute between these events, there was a clear distinguishing between the babies who developed retinopathy and those who didn't. And this is something we're exploring right now. As I say, we have a grant under review to see if we can explore this in greater detail. And maybe one of the messages that I'd like to leave you with, maybe if you remember one thing from this presentation, remember that consider intermittent hypoxia as oxidant stress, which sort of sounds paradoxical, doesn't it? But it really isn't. Intermittent hypoxia, recovery of oxygenation, oxidant stress in turn can be pro-inflammatory, and this can play an important potential role in the pathobiology of disease. Something to think more about as we move forward. Something we're not that attuned yet in our populations to appreciate. Okay, so let's move on and maybe get a little more practical and say a few words about what we are to do about all this. I'm going to touch on a few interventions. There are 3 interventions that I think we accept very readily. The first is, I think, on day 1 in the neonatal intensive care unit, we teach our trainees if the baby has a bunch of apnea, which is new at 3 o'clock in the morning, that baby might be septic. Say a few words about CPAP, xanthine therapy, and just touch on a few other proposed interventions very briefly. This is, I think, nice work, and the only work of its kind, really, is from the group led by Hugo Lagercrantz at the Karolinska in Stockholm, really showing a role for prostaglandins in the respiratory inhibition associated with sepsis. Remember I said a word about prostaglandins earlier? It's probably also playing a role in inhibiting breathing in the fetus. And they have developed a rat pup model a number of years ago now. They injected a pro-inflammatory cytokine, IL-1 beta, intraperitoneally, which is the easiest way to access a rat pup. They got a systemic immune response, and they showed that the exogenously administered cytokine at the blood-brain, cytokines probably don't cross the blood-brain barrier very well. However, at the blood-brain barrier, the cytokines were able to upregulate, to stimulate cyclooxygenase, which is one of the enzymes responsible for the production of prostaglandins, and the prostaglandin receptors at the blood-brain barrier were activated by the prostaglandin released. So I think prostaglandins are a likely mechanism whereby sepsis induces apnea. And I still think if you've got a septic baby, you better give the baby antibiotics and not give the baby indomethacin, but at least it explains a little bit about why these babies are presenting with apnea. And of course, we all know in some of our cardiac patients, when we give babies prostaglandin, we have to be a little bit concerned that the baby might stop breathing. So CPAP has been around for a while. Gosh, 1970, that's 40 years, isn't it? 1975. This was sort of stumbled upon, just from a historical perspective. I think it's quite interesting because the early 1970s in neonatology, A few old-timers like Rich and George were around. In the early 1970s, of course, the big revolutionary observation in neonatology was the development of CPAP by your colleagues at the University of California in San Francisco and George Gregory, and it really was a major breakthrough that CPAP was able to enhance the gas exchange in babies with hyaline membrane disease or surfactant deficiency. And what was really observed by chance was that as these babies came off CPAP, because many of them, of course, got better, and this was before exogenous steroids and before exogenous surfactant therapy, as they came off CPAP, because their lungs were getting better, they started having a bunch of apnea. And when they went back on CPAP, they had less apnea. And this was really poorly understood at the time, but this was the observation that was published many years ago by John Catwinkle, showing that the number of apneic episodes over time on the vertical axis could be significantly diminished in almost all the babies when the babies were on CPAP. It took almost a decade to figure out what's going on, and I'm not going to have time to get into this in great detail. Suffice it to say that what CPAP is doing, it is splinting, it's doing a bunch of things. It is certainly splinting the upper airway, much as in an adult with sleep apnea syndrome. There are many adults who are on CPAP because of apnea, and what I talked about earlier in terms of closure, or loss of tone and closure in upper airway muscles, CPAP is probably maintaining patency of the upper airway. At the same time, it's increasing lung volume, and I think I told you earlier that if you've got a low lung volume, you're much more likely with a short respiratory pause to desaturate, so it's probably increasing FRC, functional residual capacity, is the amount of air in the lung at the end of expiration, and obviously as a result improving oxygenation. So this is all good. Then of course this is a standard part of our armamentarium. What many of our patients in North America, and I suspect in Europe and other places as well, are actually on nasal cannulas. A nasal cannula is sort of I would say a poor man's way of giving CPAP, but everybody likes it. The babies like it, the nurses like it, the mothers like it. There's less pressure involved, less squishing of an apparatus up to the baby's face. And I suspect what CPAP is doing, what cannulas are doing, is simply delivering CPAP. And these are data almost a decade old now from a group in Canada showing that in infants of, let's say, 1 kilogram size, as you see here, a nasal cannula flow of about 1 liter per minute is actually effectively giving you a CPAP of about 6 centimeters of water. The problem is there's different ways of delivering different kinds of cannulas. There's some controversy associated with what is the optimal cannula. It's probably not as well controlled as CPAP is, and I think many babies, at least initially, should be on CPAP, but it's certainly, I think what the cannulas are doing in these babies is giving CPAP. The 1970s was also another interesting time. In fact, the first observation that xanthines were effective was actually not by these two groups in North America. It was from a smaller study that was performed in England about 1974, and I think, like in many cases, the group that did that probably don't get enough credit for this, but they gave babies theophylline and showed they had less apnea. But most of the credit goes to the group at Yale and the group of Jacaranda at the time in Montreal, showing that whether you give theophylline or whether you give caffeine, these are both xanthine drugs, that you have a significant decrease in the incidence of apnea. And of course, the rest is history, as they say. For a couple of decades, we worried a little bit about all these babies who were getting xanthines because xanthines inhibit phosphodiesterase, which breaks down cyclic AMP. Therefore, you have an increase in cyclic AMP. Might this have potential detrimental effects? And I think everybody in this room is aware of the work of Barbara Schmidt, she wrote this editorial, I think it's nicely worded, over a decade ago, which was methylxanthine therapy in premature infants, sound practice, disaster, or fruitless byway. And she, of course, embarked on a study that some of you in this room may well have been involved in, where she did a study. It's actually interesting that I remember reviewing this grant for the Canadian Institute of Health Resources, and there was actually a hypothesis. Her hypothesis was that xanthines were harmful. What always disappoints me is when you read the subsequent manuscripts in the New England Journal of Medicine, nowhere does it say, we hypothesized that xanthines would be harmful. Of course, thankfully, they were not. And maybe the journal didn't have space for that. But that was where she was actually, that's where she was coming from. And of course, we know now from her very nice studies that xanthine therapy was able to decrease the age at which the baby was extubated by about a week. So the babies were extubated about a week earlier, and the babies came off supplemental oxygen about a week and a half earlier. So by definition, we had a decrease in the incidence of bronchopulmonary dysplasia, which of course we don't define very well, but Judy Dashner is going to tell us about bronchopulmonary dysplasia. Maybe she'll have a better diagnosis than just how long the babies are on oxygen. And of course, in addition, she was able to show that their neurodevelopment, as a bonus, that their neurodevelopmental outcome, at least at 18 to 21 months, was improved with a decreased incidence of cerebral palsy, and a lower number of infants with a developmental quotient of less than 85, and a decrease in retinopathy of prematurity, which would be consistent with what I was saying earlier, that if you've got these hypoxic events, if you have less apnea, that you might have less of a problem with retinopathy. What we still don't quite know, and I think this is a story, we often talk about bench to bedside, but I think this is really bedside to bench. We really don't quite understand how caffeine is helping these infants. We can all assume that they're having less apnea. I'm sure they are. This was not measured in the studies that Dr. Schmidt did, and I think there's a little bit of criticism by some who say that should have been measured, but that's not fair criticism because I've already told you how complicated it is to measure apnea. You need to measure airflow. I guess we could have measured oxygen saturation and heart rate and so forth, but that's fine. I think it's reasonable that that was not done. So we have to assume that these babies are having less apnea. Well, I'm sure they are, and that there's a result of having less apnea. That's why they're getting better. The mechanism, caffeine inhibits adenosine receptors. There's a whole bunch of adenosine receptors. It's a complicated story. And in fact, there's a very interesting, this is what I mentioned as well, that xanthines, not only do they inhibit adenosine receptors, they inhibit phosphodiesterase, although this is widely believed as not being important in the sort of concentrations of caffeine that we give our infants. And we have expertise in the room in the form of Tom Young and Carl in terms of pharmacology, so I'll be careful here not to get into areas I don't really know very much about. The point that I want to make is that while we assume it relates to increased respiratory drive, there's a very interesting story about adenosine, caffeine, and inflammation. And we have some manuscripts that are coming out that unfortunately I don't have time to present this morning, showing that in an animal, and others have data as well, in a pro-inflammatory animal model, if you give caffeine postnatally, you will significantly decrease the inflammatory response. Now, rat pups and mice are not our patients. If you research the literature on adenosine as being adenosine and inflammation, some of these receptors are pro-inflammatory, some are anti-inflammatory. It's not a simple story, and it probably depends on the species. It probably depends on the concentration of caffeine. It probably depends on the receptor being activated. But I just would like you to keep in mind that maybe caffeine is also modulating the inflammatory response, maybe even also eliciting some bronchodilation. Peter Davis from the University of Melbourne in Australia, who is working closely with the Schmidt group, actually was able in a in sort of a subsequent analysis to show that decreasing respiratory support for these infants was probably the major factor contributing to the beneficial effect of the drug. And of course, as a result of that study, the use of caffeine has actually changed quite a bit. This was a survey that one of our fellows did. He's publishing, he's actually, I think this is in press at this time. He did a survey of North American and other international sites looking at the indications for caffeine therapy before and after the CAP study, which was the caffeine study. And in fact, what you see here was that before the, I think this is, let me see if I've got this. This is the percent use of caffeine in the study of Dr. Schmidt's. The percent use of caffeine, it was predominantly therapeutic. In other words, it was almost always given for babies who were having apnea, as decided by their physician, or babies to enhance their ability to extubate. After the study, what's happening now is that prophylactic caffeine therapy is being widely used, as you see here. So in fact, the indication for the use of caffeine has changed from that study. And maybe that's appropriate. So in fact, I'll often come in the morning and the baby will have received surfactant, the baby will be on CPAP, and someone has started caffeine on the baby. And maybe that's okay, but it's interesting, and I think it raises the question that when the use of a drug is so widely extended beyond the indication for which a benefit was shown, I guess maybe one needs to wonder if that's appropriate. So prophylactic caffeine, as you see here, is now being very widely used. And before I leave this subject, we all know now that at 5 years of age, the results have been a little more disappointing. I'm not quite sure how to interpret this. I think all I can say is that neonatal caffeine therapy at 5 years of age was no longer associated with significant improvement without disability. And on the other hand, maybe that was too much to expect. There's so much that goes into the longer-term survival of our patients. And I suspect this therapy is here to stay. I'm just going to say a couple of words about each of these therapies. Let me start by saying change in baseline oxygen saturation. I'm just going to show one slide because this is a study that's in press in the Journal of Pediatrics, something that we've done fairly recently, which is sort of provocative. We could spend 10 minutes now talking about what is the optimal baseline oxygen saturation at which we should keep our infants. It's a subject of considerable controversy, and I think you know the fact that there are several studies out there that have suggested that if we keep the baseline oxygen saturation on the low side, that there is an improvement in ROP, but on the other hand, there may be a price for that, which is increasing mortality. And this is still a work in process, and I don't think anyone of us work in progress, and I don't think any of us quite know the mechanism for the increased mortality in those studies that have shown low baseline oxygen saturation is associated with that. We looked at in the support study, which is one of these studies, we looked at the incidence of intermittent hypoxia. And I can just show you this. Here you see the babies who were targeted at a relatively high baseline oxygen saturation, which is the red dotted line. You can see their DSATs went up, as I showed you earlier, and then they came down over time. In the babies who were targeted at the low oxygen target, which is the blue line, which is the group of infants who are in the high 80s as compared to the low 90s, their intermittent oxygen saturations, as represented by this blue line, and you can see the 95% confidence intervals, stayed high. So all I can say is that if you target the babies at a low oxygen baseline, these oxygen desaturation episodes are going to last much longer. Whether this has anything to do with later morbidity or mortality is pure speculation. But I think it's of interest, and as I say, it's in press, and you're going to read about this relatively soon. There's an interesting story out there about whether transfusion helps babies with apnea. This is a story that's been out there for maybe 20 or 30 years. The most recent data on this, again, is from the group at the University of Virginia that I alluded to earlier, showing the effect of transfusion on apnea with associated bradycardia and desaturation, which is how they defined these episodes. And you can see the number of events did go down. The events greater than 10 seconds, 20 seconds, and 30 seconds did go down after transfusion. This slide also shows, by the way, if you look nurse on the bottom here, nurse apnea and bradycardia, that if we rely on nursing recording of these episodes as compared to recording what really is going on, we will greatly underestimate the incidence of these episodes. So transfusion has got its own hazards, it's got its own challenges. That's a whole talk in its own right. But I think there probably is some evidence that these episodes are diminished after transfusion. And it's probably not that they have less apnea. in data that I don't have time to show you, is probably because with a given apnea, they are less likely to desaturate, which makes sort of physiologic sense to me. If you've got more red cells around, you've got better oxygen carrying capacity, you now quit breathing, your stores are probably better, and you're probably less likely to desaturate. And I'm going to skip those 2 slides. This is some work from the University of Winnipeg in Canada, a group that was led for many years by Enrique Regado, which is a name I'm sure you're all familiar with. And he did a study actually over a number of years where he gave babies a very low concentration of 0.5% CO2 and showed that these babies were having less apnea. In other words, this low concentration of CO2 was actually not raising their CO2, but it was just enough to increase their respiratory drive, much as you see here by the blue lines. When the babies were getting a low concentration of CO2, the number of apneas decreased. On the other, that's with the orange, I'm sorry, theophylline was the blue. Of course, theophylline was more effective. So I think this is interesting physiologically. I don't suggest that you go home and tell your staff to give babies low CO2. I think they would probably resist, especially seeing many of our infants already have a high CO2 to begin with. Of course, this study also ran into the beneficial effects of xanthines, which occurred about the same time. So I'm not sure this therapy is ever going to catch on in a big way, but it's interesting. Just a couple of words about a phenomenon that is often associated with apnea of prematurity, which is gastroesophageal reflux. Gastroesophageal reflux, much as apnea, is a developmental problem. The two may at times be physiologically linked. They both exhibit natural resolution, and they both may be manifestations of developmental immaturity. Reflux is actually very rarely in the premature infants associated with apnea of prematurity. This is a study that we published a couple of years ago, and this is the incidence of cardiorespiratory events, as you see defined here. An apnea more than 10 seconds, a desaturation to less than 85, and a drop in heart rate to less than 80. And only about 3% of these episodes are ever temporarily related to gastroesophageal reflux. Let me repeat that if you get a large body of data out there, even though people will sometimes attribute apnea to reflux, only about 3% of such episodes will ever be associated with gastroesophageal reflux. So to treat the gastroesophageal reflux and expect that that's going to decrease your apnea, it's pretty unlikely, when only 3% of such episodes even have the potential of being impacted. And in fact, there are studies out there, such as this study from the University of Texas in Houston, from the group of Kathleen Kennedy, showing that in fact when they treated with either metoclopramide or ranitidine, in other words, acid suppression therapy or pro-motility agent, you can see there was no evidence that that treated group in pink had a decrease in the number of bradycardic episodes as compared to the placebos. In fact, it went the opposite way. For whatever reason, the placebo group did better. And we also know that acid suppression therapy actually may be not good. There is good evidence, increasingly emerging evidence. This is data from Susan Orenstein, who is a pediatric gastroenterologist in Pittsburgh, showing that if you give acid suppression therapy, the efficacy is poor to non-existent, and there is a significant increase in adverse events, particularly in the form of sepsis. So please don't think that acid suppression therapy, which is very unlikely to impact such episodes anyway, is a particularly safe treatment for our patients. Let me conclude. Give me about 2 or 3 more minutes just to say a little about the resolution of these episodes. It's a problem when babies are ready to go home, they're taking their full feeds orally, their thermoregulation is well controlled, and they're sort of stuck because monitor alarms are going off and they're having apnea and bradycardia. These are some data from about a year ago from the group of Eric Eichenwald, who is now at the University of Texas in Houston. Here you see the last home apnea, the last home monitor alarm, and you can see that in the babies who had apnea, the age, the post-menstrual age or the corrected age at discharge was significantly higher, as represented by the squares versus the circles. So I don't think this is just confirming what I think we would all suspect, that if you have persistent apnea, you're going to stay in the hospital longer. And we have all sorts of pressures in our country and probably in your countries as well to get both from parents and care providers to get these babies home. So this is a bit of a challenge. This is in your syllabus, and I'm not going to, you can look it up if you like. It's a template that we have employed to try and decide when to stop pharmacotherapy in these infants. If I can just summarize briefly what's on this template, we try to stop the caffeine on these babies well before they're going home. So we are usually successful about 3 weeks before these babies are typically discharged to stop the caffeine therapy. And it is only on rare occasions, it does happen, but it's only on rare occasions that we are really forced to restart the caffeine. So typically we stop the caffeine around 32 weeks in a baby who's going to be going home at about 35 weeks corrected age. If they're alarm-free for about a week, we send them home. Sometimes the events recur. If no intervention is required, we continue in-house monitoring. If intervention is required, we will occasionally do a pneumogram. We will consider to restart the caffeine, although I'd like to emphasize that happens only in a minority of infants. If the babies are then continue in-house monitoring, if the babies are alarm-free for about 5 days, we send them home. If the alarms persist, we will occasionally send a baby home on a monitor for a short period of time. This represents about 15% of our babies less than 1,500 grams. I wish it was zero. It's a terrible practice. I think it drives families crazy. Unfortunately, in our setting, there is still a small number of babies who will have to go home for a short period of home monitoring. And I think I discussed this a little bit last night with Gunnar. This can be a little bit of a problem, certainly in Belgium as well. There was one study that was done that I was pretty actively involved in called the Chyme Study. And this basically was an observational study done about a decade ago. And I think it did change practice. We had 3 groups of infants, a group of premature infants who were still symptomatic at discharge, a group of premature infants in the open yellow circles where the apnea had completely resolved, and then importantly we had a group of healthy term infants as represented by the green. And not surprising, the babies, the preemies who went home starting at around 33 to 34 weeks, still had apnea in the home, not necessarily causing a problem at all. These apneas declined over time, as you can see here. And by the time the babies reached about 43 weeks corrected age, there was with a study that had good power, there was no longer a difference in the number of apneic episodes they were having, longer episodes of apnea that they were having compared to the green babies who were the healthy term infants. And what this has really done in our communities is for the odd baby that needs to go home on a monitor for whatever pressures, we can almost always stop that home monitor when this baby gets to about 43 weeks corrected age, which is quite different to a decade ago when a lot of these babies stayed on monitors for a long period of time because people were worried about sudden infant death syndrome and so forth. This is a study I picked up from our colleagues here in Leuven. I noticed that there was a paper a couple of years ago in ACTA where you did pneumograms and you looked at the effect of apnea on hospital discharge. And I think this is consistent with what I just said. If we look at post-conceptual age on weeks, you can see around up till about 43 weeks, these babies will still have episodes. These babies, I think, were monitored at home. Starting around 43 to 44 weeks, there was only the occasional baby that still had episodes. And of course, there's no term group here. And my refute to this would be, this is an interesting observation, but I suspect if you had a group of healthy term babies, you would also see some of these episodes. And we can't be monitoring everybody in the home. So I think it's reasonable to stop when these babies get to an age such as this, if they need monitoring at all. So there's some challenges that remain. I'm sorry this has been a little bit rushed, but I have had a fair bit of ground to cover. We haven't said too much about the role of the accompanying bradycardia that accompanies these episodes, although, as I said, the group of the University of Virginia have used this as a predictive tool. Is there any role for the accompanying hypercapnia? Because we've talked a little bit about intermittent hypoxic episodes. My hypothesis is that these intermittent hypoxic episodes, their reoxygenation, their potential pro-inflammatory effects may not be benign, but we have a lot of work to do. I don't quite know what to do with the degree of hypercapnia that might accompany these episodes. Is probably fairly modest. Again, I'd like to leave you with the message that resaturation or recovery may be as important as the event itself. Is there a relationship between these events, apnea, intermittent hypoxia, and outcome? It's hard to know. First, there's two problems here, right? First, is there a relationship? And then if there is a relationship, is it causal or is it purely an association, right? Because the baby that takes a hit in utero may be the same baby that has a lot of apnea postnatally, and that doesn't necessarily mean the apnea is causing a problem. So let me leave you with this. I'm just showing you one last slide, and I don't know whether, is Saryat in the room? I know Saryat Supapanachar was going to come, my colleague from Bangkok in Thailand. He's a good friend, and I think he's coming to the meeting. I guess he's not here yet from Bangkok, but we do, for those of you that are in that part of the world, for the last few years, you can see some, that doesn't show very well. This is Rich Poland and Judy Ashner looking a bit odd in a hat. But we sort of have a lot of parties and we have a lot of fun, and if any of you are in that part of the world, I know you are from Indonesia, we look forward to welcoming you in Bangkok in a nice time of year and a fun place at the end of January. And I believe IPOKRaTES also was recently in this region. So thank you very much for inviting me, and thank you for your attention.